And I give over to Dr. Olvina D'Souza, Secretary of Navi Mumbai, to conduct the proceedings and to introduce our speakers. Dr. Olvina, thank you.
So, as Dr. Jesse said, today we are celebrating Day for Safety and Health at Work. So, today we'll focus on the magnitude of different hazards in war, where we spend most of our working time, and how creating a safe environment can reduce the workplace related health hazards. So today our first speaker is Dr. Reena Gautam, who will be speaking on environmental hazards in OT. Varsha, can you put Dr. Reena Gautam's CV slide, please?
Yes, ma'am.
So Dr. Reena Gautam is working as a consultant anesthesiologist since 20 years in Thana and Navi Mumbai. Her special interests are general anesthesia for pediatric and geriatric ophthalmic cases. She has multiple presentations at Annual Conference of Ophthalmic Forum in Indian Society of Anesthesiologists 2015 AIMS Delhi, 4th World Congress of Ophthalmic Anesthesia in 2016 Chennai, Asian Society of Pediatric Anesthesiologists in June 2017 Mumbai, Maharashtra ISACON Nanded in October 2017 and Shirdi in October 2018. She also has won awards for best presentation in BA faculty contest at ISACON Nanded 2017 and outstanding and ethical medical services in humanity by Shri Bhairav Charitable Eye Hospital Bhiwandi. So over to you, Dr. Reena. Reena, you are able to share your slides?
You are mute, Reena ma'am.
Yeah, I'll just share my screen.
Yes, ma'am. Yes.
Is it visible now?
Yes, ma'am.
Okay. So on today's occasion of, first of all, thank you for giving me the opportunity. I'll be on today's occasion of World Day for Safety and Health at Work. I'll be talking on environmental hazards in the operation theatre. So as we all know, our health sector is one of the dangerous lines of work in which occupational health and safety are becoming increasingly important. The operation theatre, where we spend most of our working time, is charged with multiple inherent risks. A hazard is a situation which poses a threat to life, health, property, or environment. And in this OT hazards, the people susceptible can be the patient, anesthesiologist, surgeon, nurses, technicians, and other OT staff. Depending on their nature, the hazards can be classified as physical, chemical, biological, electrical, psychosocial. Since this is a vast topic, in detail, I'll discuss a few of them. So we'll start with physical hazards. Injury to body parts due to stabs and cuts from sharp objects, blades, ampules are the commonest hazards in OT. There can be falls, slips on the wet floors. In our ophthalmic OTs, we have to be very careful about the microscopes. Usually, many times during extubation, I get hurt with the microscope. So these are the simple ones which are very common. And in recent times, mobbing, violence are also increased. Coming to the physical hazards, the sanitizing agents, disinfectants, if improperly exposed to, can cause injuries. But the most significant to us in this is the pollution by anesthetic agents. And the foremost in this is nitrous oxide. which is extensively used worldwide, and probably the only anesthetic agent which has traveled through the history of anesthesia without losing its actuality. Due to its weak anesthetic potency, it has to be used in high doses, due to which all the anesthetists suffer occupational risk. It can cause headaches, dizziness, nausea, vomiting. The neurological symptoms can start with tingling or numbness in the extremities, and very rarely, sometimes there are reports where it has led to subacute combined degeneration of the spinal cord. The hematopoietic effects can be thrombocytopenia, leukopenia, and in long term, this can lead to immunological disorders. Nitrous oxide also irreversibly deactivates methionine synthetase and leading to megaloblastic anemia and hepatic toxicity. It can cause beta adrenergic stimulation. There are so many studies which show increased incidence of teratogenicity, spontaneous abortions, decreased rates of fertility. After nitrous oxide, this is a survey of nitrous oxide, which was done in 2007 in India in among 400 anesthesiologists. And the results showed that in 2007, 27% of the anesthesiologists, of whom 50% were neuroanesthesiologists, had decreased the use of nitrous oxide. The factors responsible for that were clinical indications, availability of medical air, and use of total intravenous anesthesia. After nitrous oxide, the commonly used agents are the volatile anesthetic agents, which have been in use since over 150 years. The initial view of volatile anesthetics as being a indispensable part for general anesthesia has evolved during the years, and now currently its use in daily use is being questioned. So these volatile anesthetics, though they are an important entity of our armamentarium, long-term exposure can cause headaches, drowsiness, fatigue, irritability, decreased psychomotor efficiency. In patients, the common side effects are postoperative nausea, vomiting, postoperative cognitive disorders, epileptiform electroencephalogram patterns, and in genetically susceptible patients, it can also cause malignant hypothermia. The different causes of the pollution, this pollution in the operating room can be failure to disconnect the low flow control valves, the flow control valves, flushing of the breathing circuit, filling vaporizers, use of uncuffed tubes, laryngeal mask airways when used for spontaneous ventilation with high flows, use of open circuits, side stream sampling of gas analyzers, occlusion of the suction system. Now, in addition to all this, one of the most important hazard is that these are exceptionally strong greenhouse gases and can pose occupational hazards. Unfortunately, majority of these inhalational agents, they last for many years in the atmosphere, intensifying their global warming effect. The atmospheric lifetime of nitrous oxide is 114 years, that of desflurane is 14 years, and sevoflurane is 1.1 year. The impact is such that 1 hour of anesthesia performed with desflurane contributes 26 times more global warming than the equivalent anesthesia performed with sevoflurane. Likewise, the addition of nitrous oxide increases the global warming effect of sevoflurane-based anesthesia by 590%. Now, apologies maybe for the poor visibility. This is a recent article on inhaled anesthetics published in 2021 by Mariana et al., where they have reviewed the literature based on 3 perspectives: the environmental impact, occupational risks, and clinical indication. They have given us a new approach to start with the question whether the use of inhalational anesthetics strictly necessary or potentially clinically better for our cases. So the authors, they have advised us to take care of the environmental impact to avoid the use of desflurane and nitrous oxide. Now, regarding this, the awareness about desflurane has really increased, and all over the countries, the use of desflurane has come down a lot, but nitrous oxide is still used very commonly. So what we can do is we can replace inhalational anesthetics by total intravenous anesthesia and local regional anesthesia. Maybe there are newer technologies will come for extraction of waste anesthesia gases. And one more option which in near future can be xenon, which is a noble gas and will be an ideal substitute for conventional inhalational anesthetics. Regarding the measures which we can take to control the occupational risk is installing the scavenging and ventilation systems, regular inspection of anesthesia equipments, improved awareness amongst the anesthesiologists, use of closed circuits and low flow anesthesia, I feel is the need of the hour, and it is practically easy, achievable approach if we have proper equipments. Also, availability of medical air is, if it is there, it can easily discourage the use of nitrous oxide. The clinical indications where this article suggests potential benefits of inhalational anesthetics in cardiothoracic surgery and renal surgery. But contrary to our routine protocols, this article highlights the potential benefits of TIVA in cancer surgery and pediatric surgery. So now it's up to us to decide how much to use the volatile anesthetics and nitrous oxide. With this, we'll come to biological hazards, where we all now, due to the COVID-19 pandemic, we all are aware of the infectivity of this disease. So in OT also, this is easily transmissible. Other diseases, infections which we can get is airborne, tuberculosis, the bloodborne diseases like HIV, hepatitis B, hepatitis C. And the commonest reason for infection of among this bloodborne diseases is the needle stick injuries. So to prevent all this, the things we can do is use personal protective devices, gloves, masks, vaccination for the diseases, avoiding reinsertion of needle into its cap, dressing of all the abrasions and cuts, disposing of the contaminated material in meticulous manner, sterilization of anesthesia equipment and apparatus. Coming to the radiation hazards, ionizing radiations can cause cellular damage by induction of DNA lesions and formation of reactive oxygen species. This leads to cell death and genomic instability, which increases the risk of malignancy. Now, the pathologic effects of radiation hazards can be deterministic and or stochastic. The deterministic effects are short-term, which occur due to when the exposure has reached a certain threshold level. And the examples of this are hair loss, skin erythema, cataract formation. More worrisome are the stochastic effects like carcinogenesis and teratogenesis. The incidence of this increases with exposure without any definitive time period or threshold levels. So the protective measures we can take is shielding, use of lead aprons down to the knees for gonadal protection, use of glasses with protective lenses to protect the retina, and collars to protect the thyroid. Newer protective gears in this are the lead gloves, and now even for the patient safety, lead skirts are available, which can be put over the OT table. Maintaining distance from the primary source of ionizing radiation will promote complete reduction of primary radiation exposure. Next come the electrical hazards. Unsafe electrical configurations can easily lead to electrical accidents. Operation theater is an unusual place where there are numerous instances of deliberate application of electrical equipments to the human body. The morbidity and mortality due to electrical accidents can be due to electrocution, burns, ignition of flammable material causing fire or explosion. Shocks can be macro shocks or micro shocks. Macro shock is when a large voltage is passed through the human body, and any OT personnel can be exposed to this, and it is usually due to faulty electrical disconnections. Micro shocks when there is direct application of small voltages to the heart, as in cardiac catheterization, intracardiac pacemakers. Regarding electric accidents, common are the diathermy burns, which can be due to inadvertent depression of the foot switch or due to poor contact between the neutral plate and the patient, resulting in increased current density. Nowadays, many patients come with the pacemakers, so we have to keep in mind that unipolar diathermy can cause permanent disruption of the pacemaker. So it's better to use bipolar diathermy. The safe practices to avoid electrical accidents are use of proper grounded equipment, ensuring the patient is not in contact with OT grounding sources, use of large grounding pads for electrocautery, use of bipolar cautery, which uses lower power output, adequate maintenance and regular testing of equipment, wearing anti-static shoes. Then coming to personal hazards, stress, which I'll not talk much about. We have our next speaker, Dr. Swati, talking on this. Then we have fatigue, drug addiction, chronic systemic hypertension, depression, abuse of drugs and alcohol. Chemical dependence is very common because of the easy availability of potent drugs, which leads to self-administration of these drugs and as a result, increased suicide rates amongst the anesthesiologists. So I would like to conclude saying that constant vigilance and awareness with timely intervention can avoid many of these hazards, and maintenance of a specific operative procedure and educated team culture can make the OT environment heaven for the patient as well as for the theatre team. These are my references. Thank you.
Thank you, Reena. It was an excellent presentation. We learned few points on biological hazards, environmental hazards, radiation hazards. So we'll take some precautions to avoid all these hazards. So I think we'll go to the next lecture. We are highly skilled professionals. We have to make quick decisions, take quick decisions and perform complex procedures under pressure. So of course we are, there is always a certain amount of stress, but problems arise when the stress becomes excessive. So today our next speaker, Dr. Swati, she will be talking on how to cope up with the stress. So, Dr. Swati Gadgil, she has completed her PG in anesthesiology in Grant Medical College, Mumbai. And after that, she has done masters in law from Mumbai University. Because we look at the CV, we can make out that she has accomplished a lot after that in India as well as abroad. She has worked a lot with the NGOs on menstrual hygiene, gender sensitivity, etc. Along with academics, she is known for her extracurricular activities also, like music, poetry, etc. So over to you, Dr. Swati ma'am.
Thank you so much, Alvina, for introducing me. Thank you. Thank you, ISA Navi Mumbai, for inviting us here today. And it is really a pleasure to speak on stress. You know, I mean, how can it be a pleasure to speak on stress? But anyways, I have to say that because we always speak of stress, but we don't think who is generating it. Okay. So every lecture, somebody or the other, whatever forum you are on, whichever branch you are, it's state or it's national level, wherever, people keep telling us what to do, what not to do. And nobody ever says, you know, like, ja Simran, ja, ji le apni zindagi. Nothing like that comes to us ever. So I keep wondering that why. I mean, we have to always remember one thing, that is, yes, zindagi na milegi dobara, you know, JNMD. Yeah, short forms, come on. I mean, in so many OTs, operation theaters, there are lots of short forms which are used. And if we are not used to it, again, that creates a lot of stress and tension, you know. If somebody says just JNMD and you're not aware of what it is, somebody says K3G and you're not aware what it is, then yes, it's going to create stress. So you have to know that yes, it's Zindagi na milegi dobara. And kabhi khushi kabhi gum, that is the story that all of us face, and that is the truth of our life. And Zindagi na milegi dobara is the underlying thing that anesthesiologists always have to remember. And that is why we are precisely, we are always very, very high strung. So the situations that we work in and the multitasking that we have to do. But remember one thing, I as a lady doctor, I know that so many women, they love to portray themselves at Ashtabhujas, like Ashtabhujas, doing so many things simultaneously. They want their pictures like with 8 hands and all behind them. No, I'm sorry. I perfectly believe that I just have 2 hands and I have 2 eyes. And I don't want to take any extra responsibility beyond that. Whatever I can manage with my 2 hands, I will do. And I will refuse to do things beyond that. Whatever is my job, what is assigned to me, I should be doing. I mean, every anesthesiologist can have such principles that, yes, I can multitask, but I don't choose to, not always. Agar aise karte jaoge, to there are people who would really exploit you to no extent. So like adjusting the OT light and things, and we have always been talking about that. Suction nahi chal raha, anesthetist bhago. Bachcha nahi ro raha, anesthetist bhago. Light nahi adjust ho raha, anesthetist bhago. Come on, I mean, things are not available, run to the chemist. Sutures not available, anesthetist bhago. No, anesthetist is not supposed to be doing all this. Anesthesiologists have to take care of themselves, saying that, yes, I have to be with the patient and just one responsibility that I have, and I'm going to take care of that. So like every morning, all of us, we reach the operation theaters, and there's a different surrounding everywhere. Some operation theaters are very, very noisy, and some are really very quiet. Why noisy? Because there is some staff who they always speak in high tone, high pitch. They are always either fighting with each other, or the things are not arranged and it is all a mess. Or some theaters are absolutely perfect. They are quiet. They don't utter a single word, as if, it's a very, very senior cardiac surgeon operating, and there's pin drop silence in the OT right from the morning. Some theaters are like that. So depends on what kind of a theater you're entering in the morning, what temperament you have that morning, and that is how your day begins. Also, the surgeons that we work with, some of them are really very easygoing, and some of them are very, very demanding. It's very nutty, I can say. Unnecessarily, they would be, having certain whims, and accordingly, we have to work with them. Now, some are always late, some are before time, and very few would be punctual. So being punctual is something that I appreciate, especially if it's the first case of the day. We all appreciate that people have to be punctual, because then the rest of the list through the day will get messed up if your first case doesn't begin on time. So these are the things. And along with the surgeon, you know what? There is one important person, one very, very important person who walks into the theater. Could be sometimes before the surgeon, or maybe sometimes after the surgeon. You know who this person is? The special skilled assistant that the surgeon always brings along with him. And this assistant also has his own whims. It's like, that chai se kitli garam. Kabhi kabhi inke nakhre jada hote hain. So that's like chai se kitli garam, you have to take care of them more, because they would be having special inputs about you to the surgeon after the case is done. The surgeon is busy operating, he's not even looking at us, but the assistant would have all the naughty things to be done around. So just beware of such people who are chai se kitli garam. So these assistants and the people around in the theater, and of course, cannot forget the family that we leave back home and come. Our kids, our spouses, our family, no doubt they are always very, very supportive. Most of us have a supportive family, but just in case it is not so, and you go home, or before leaving your house, you have some trouble in the house, then you have to learn one perfect technique of a regional block for yourself. What's that regional block? It's the block where you block your senses above your shoulders and just have one reflex of nodding to say yes to everything and then walk out. That kind of perfect regional block for yourself, if you can achieve, nothing like it. So just train yourself for that before you start your day, and also when you end your day. So that can buy some peace for yourself. That can manage your stress a bit, because if you try to react and respond to every kind of stimulation around you, the moment you wake up and you start your first case, it's going to be a hell, surely. Now, another thing, like Dr. Reena was telling us about all the things that we have to check and the gases and the inhalation agents and all that, that could be hazardous. I wonder, my title today is Breathe Easy. After having heard her talk, I was wondering whether we should breathe at all or no. I mean, there's so much around us. So should we just stop breathing? No. She gave us perfect solutions about what agents we can use to make it more safe. But yes, that's how we have to be very alert and aware about all the equipments and things around us in the theater also. See, when I'm talking about our stress, I cannot just try and ignore the settings in which we work. So I'm going around all this first, because that is a part and parcel, a major part of our life. So the equipment checks, we have to do that. And let me tell you one very important thing, and that is the oxygen supply in the theater. There have been real incidences, where the assistants or the theater staff will tell you that, yes, I had checked it last, raat ko dekha tha, cylinder full hai. And when you need it and you open, it's not there. I mean, it's either empty or there would be only very little left in the cylinder. So please, to cut down your own stress, spend those few minutes checking these things before you start the patient always. Because agar aap ye check nahi karoge, then surely there's going to be stress and you cannot breathe easy without doing all this check. If you breathe easy without checking these things, then surely you will suffocate later and don't want to have that kind of a catastrophe. So please check all these things and then start the patient. And also you can declare that I am going to take this time to do my check, whatever hurry the surgeon is in. Don't bow to his pressure. Induce karo, even if he wants to put the patient in position and paint and drape and not giving you time to take the history or do things. History taking, of course, PAC, if you can do it the day prior, it's nothing like it. It's wonderful. But if you cannot, at least spend some time before you induce the patient to reduce your own stress. Don't bow to pressures of people around you who try to tell you how to do your job. You can tell them, I know my job. Let me do it my way. So learn to say no, learn to say yes to certain things. When to say no is so very important. Now, what bothers us most, and something that, the short forms and mnemonics have always been a part of our life. So now I'm going to talk about what bothers us most is 60s. I'm not talking about 60s. I know we are all 16. None of us is 60s. But I'm talking about 6 T's. That is T. Okay. So what are these 6 T's? They are our thoughts, our temper, our timings, our theater dynamics, our tiresome days. And of course, last but not the least, T deficiency. This deficiency can really trouble us and bother us a lot. All of us mostly are used to having lots of tea through the day. So these 6 T's I want to talk about today. Please remember that what thoughts you have in your mind. See, we eat food for our body, for our physical energy. So that is something that we consume and goes into our stomach. But what is the food for brain? What you eat for your brain is so very important. Every day, every morning, through the day and night, what you eat for your brain really matters a lot. What are the inputs that you have for your mind? They matter a lot. What you absorb and what you bounce off is so important. If you start absorbing everything around you, there could be a lot of bad food coming in for your mind. So your thoughts, what you think, what you see, what you absorb is something that you have to be really mindful about. Being mindful is so important. Mindful of every step, mindful of everything that you listen to, mindful of everything that you speak, that you say, every word that you utter, every action of yours. So being mindful. Take care of your thoughts. Your thoughts have to be really pure. You can do this after certain days of habit. You have to develop these habits. These skills, they just don't come overnight. That yesterday I decided I'll have positive thoughts, that I'll have calmer mind. This will not happen overnight. It can happen over training of few days, few months maybe, and some of them fail even after that. So even after a lot of meditation and techniques, at the end of it, if there is a smallest of trigger, they would start yelling and shouting and everything is messed up. I'm sure all of us, you will believe when I say that if you are angry, if you shout at someone, if your thoughts are very disturbed, you will surely have one or the other problem in the theater or with your own self. Let me share one small thing. Just this morning, I can tell you. I had a list of cases of which, unfortunately, few patients got postponed. Somebody got postponed, somebody did not turn up. So I suddenly had, like rest of the day was free and I didn't know what to do. And it was really actually disturbing because my plans were all according to the number of cases that I had. And this one thought, and I was walking out of one of the hospitals and I twisted my ankle and I fell down. Literally, I fell down. I got up, I managed to get up without any help. Fortunately, I'm okay. I'm still at home. I'm not hospitalized, no fractures. But I see this is what I'm trying to put across, your thoughts, being mindful. If you are engrossed in certain thoughts all the time and you lose the context of where you are, what you're doing, it is surely a recipe for disaster. So mind your thoughts, mind your temper. The day you are yelling at people, you will surely have some complications in the theater or at home or while driving or wherever. So try not to yell, try to control your temper. What was told to us by us seniors, our grandparents, that please start counting numbers, say 1 to 100. Now, why this 1 to 100 is you just have to spend that much time so that your tempo goes down. Your immediate reactions can always create trouble for yourself and others around you. So thoughts and temper is something that you have to take care of. Then the third T that really troubles always is adjusting between the cases. So many things that we have to do during the day and the clock is running and we have to keep up with everybody's timing and we are rushing from one place to another. Or if you are in the one theater also, you are rushing from one table to another, taking care of all the patients and everything. So how to make best of the time that you have? Time management is something which is really very important. And in this time management, you have to fit in your food intake also properly. You should never be skipping your breakfast and lunch because empty stomach, you would never be thinking straight. Your stress levels will surely go high if you have not eaten anything properly. Never start your day without your breakfast and even your lunch. If you are through the day in the theaters, you please try to eat something and something healthy. Don't try to call in for samosas and vada pavs every day just because that's available around and it's tasty. Yes, it is. But we cannot afford to eat that every day. A simple roll of ghar ki sabzi and roti, that if you can carry, or if you don't have anything else, you can just pour some oats and milk and almonds in that and carry it to the hospital. So have something healthy. Carry a fruit with you. Always have some dry fruits in your bag. It's not difficult. Because unless you have good energy, unless you have right things to eat at the right time, which will not really consume much of your time between the cases, you cannot function properly. So take care of your food when I'm talking of timing. And most importantly, in this time management, you cannot skip getting good 7 hours of sleep. Don't try to be superhuman beings. Don't try to boast that, yes, I work only on 4 hours of sleep. Nobody can become Nehru or Modi overnight. Nobody's going to give you a medal for that also. Please, we are normal human beings, I suppose so. So then get 7 hours of sleep. You can refuse one or the other call. There are other people who can take over the cases for you. You can share, you can call your friends and ask them to go if you are tired, if you haven't done, you are not done with your sleep. Don't exhaust yourself to the edge. If you are on the edge all the time, you will create stress for yourself and others around you. And then nobody's going to like having you in the theater. Because if we are stressed, the surroundings also get stressed. There is a lot of negativity that we throw around. There may not be any smile. Our eyes would be swollen. We are tired and want to sleep, then sulking and yelling. So what are we achieving by doing all this? We want more cases. We want to be more busy. We want more money. Yes. How much are you going to accumulate? And for what? Are we sure how much we want? Okay, I desire to have a Mercedes. I desire to have a big, huge duplex house. I desire to have a house at Marine Drive in Mumbai. I get that. Do my desires stop at that? Having done with that, I would really always want to have something beyond. Then I would want to have Antila. I would want to become Ambani. There's no end unless I put certain limit to myself. I'm not saying that we have to clip our wings. I'm not saying we have to have a low aim. You can always think high. You can always aim for bigger things, but not stretching yourself to the breaking point. Look for satisfaction somewhere, look for peace somewhere, and it is what somewhere? Where somewhere? It's within you. You don't have to go anywhere to look for it. You just have to close your eyes, look within, and peace and happiness well inside there. And that this is something that we forget. So your desires, your peace, and especially, when we say, I want peace, you'll never get it. Because the sentence begins with, I want. It's a desire. The minute you get those two words, I want, out of your dictionary, you will get everything. The minute you remove I want, what remains is peace. So never say I want peace. You just remove I want and you will get peace. Believe me when I say this. I'm not trying to demotivate you. I want all of you to be the topmost anesthesiologists in your town and in India and abroad. But please, that can happen only if we have sane mind, if we have a healthy body, a healthy mind, correct? So these are hedonic adaptations and eudaimonic lifestyle. What is hedonic and what is eudaimonic? Hedonic is something like just now I said, I want a car, I want a big house, and I get that and I enjoy it and I'm very happy and I'm boasting about it. For how long? Maybe 8 days, 10 days, a month, couple of months. I would be doing housewarming parties, calling people, clicking pictures, uploading on all social medias. How many days would I upload pictures of my new house? Couple of months, not beyond that, surely. We get used to it. And the happiness is over, it's gone. Then we want something more. So then there's no end to it. So beyond that, what we have to look at is the spiritual side of our life, which is surely there, because none of us know why the heart starts beating and when it stops beating and why it stops beating. We just know that zindagi na milegi dobara. We have to be cautious. So live like, every day, live like today is the last day of my life. So being nice to everyone. Why everyone? Be nice to yourself first. If you are nice to yourself, surely you would learn to be nice to others as well. So treat every day as the last day of your life and just try to be happy, smiling, creating positivity. I know this sounds very much like a therapist, positive thoughts. Where are they sold? Can I go and get them from the market? Positive thoughts, somebody who is feeling depressed, people who are driven to suicides. Do you think that they are not aware of positive thoughts and negative thoughts and all this shit that we talk all the time? Of course they are aware. And we surely fail to understand what drives them to end their life. And we are all around them and we feel bad that we couldn't stop it. It's not so easy. It's not so simple. Talking about our psyche, talking about being bipolar, talking about being hysterical, talking about being depressed. Why do we avoid talking about all this? Please speak up. If anybody of us is feeling depressed, anybody is feeling off color, try sharing your woes with your friends. I'm saying try. I'm sure that we cannot speak about everything that's going on in our life with others around us. We keep it within us and we suffer. But then have some friend, some sort of a person, some faith somewhere. Do you know that faith heals? The simplest of mind, which believes in God, a child which believes in God, a child which believes that maybe Jesus or Ganpati Bappa or somebody or Allah is going to give him everything that he wants. He just closes, or the Santas want to get the gift for him. The simplest of childlike mind, which closes his eyes and says, oh, I want this, I want my chocolates, I want my dolls, I want my Christmas gift. And they get it. And that faith works. Somebody says, I just want this particular thing and I don't know how to get it, but I don't know. God, you have to give it to me. I want it. And that gives them that particular energy to walk on that path and achieve it. We have to be focused in some form. If we try to change our path daily, if we are not walking straight on one path, you are surely not going to reach your destination ever. So please try to not lose your vision, your path, your walk, your mind, your calmness, and your happiness. So don't try to lose all this. Now, achieving this, like I said, is not easy, but breathing techniques are very important. My title is Breathe Easy. Please try to analyze how many times during the day you are not breathing properly. We talk of tidal volumes. We set the ventilator settings for the patient. And who's going to set the settings for yourself? For us. So we have to put the settings for ourselves, and those settings have to be perfect, like a deep breathing technique. Each one of us has to practice through the day. Though the gurus would tell us that meditation and pranayams have to be done in the morning, yes, you can start your day with it. Always make it a habit to start your day with good breathing practices. But through the day also, you have to do that. The minute you feel you're getting agitated, you want to control your adrenaline, you just have to close your eyes, take a deep breath, and exhale fully. Most of the times we are not even exhaling fully, and that causes problems. So learn breathing techniques, learn your meditation techniques, whatever you can, increase your own tidal volumes and feel good when you really have good inhalation and exhalation powers. So, and gym, yes, I am seeing these days that most of us are into gymming and running and jogging and cycling and all those things. I can almost say, you can try to avoid your gym. I mean, don't laugh now, because why I'm saying this is that gives us overconfidence of our muscle power, and you can get tempted to use it sometime in the theater if somebody is not behaving well. This has happened when we were training when I was training for karate. I'm a taekwondo expert, and my son was also learning with me. This young boy, doing karate every evening with his sir, and he would go next day to the school, and some boy not listening to me would just kick the person around. And then the teacher called me, Adam, please stop his karate classes, because the minute somebody says something to him, he starts kicking around. So that's why I'm saying, gym you can avoid. Don't try to be overconfident of your muscle power. Don't try to show your biceps and triceps in the theater, but try to show off your cool mind in the theater. Try to show off your positivity. Try to show that how happiness can follow you. Wherever you go, there is happiness. Wherever you go, there is pleasant feeling. And that is how you'll surely have more number of cases. You will surely not lose any of your hospitals, even if you say no to a particular case. If you have a good temperament, which you can pass on to others. Having a good temperament for yourself, it's definitely healthy. Passing it on to others is more healthy, because that way you can create a perfect surrounding and atmosphere for yourself also. And then universe will conspire to make it happen, whatever you decide. So your positive thoughts and the universe together can make you achieve anything and everything that you want to. So you have to control your body, your mind, your emotions, and your energies. So if you achieve a perfect control on these four things, you will surely you will surely be stress-free. Trust me when I say this, and I think let me stop at this. So, Zindagi na milegi dobara. Please give a big smile. You all can put on your videos, and I want to see you smiling. Can I request all of you to just switch on your videos? I want to see your smiling faces. Yes, I can see Reena, I can see Jayashri, I'm seeing Dr. Nilesh, Manoj sir, Manisha ma'am, Jessie ma'am. And there are a few more who haven't, probably they have just put the screens on and they have disappeared, I suppose. I know how many of them have heard my lecture. No, I'm just joking. So bye-bye. Have a great evening ahead. I'm eager to listen to Dr. Nilesh. You were fantastic. You've covered most of the points that were really important for all of us. So I'm keen to hear Dr. Nilesh now. Thank you, all of you.
Thank you so much, Dr. Swati ma'am. It was an amazing lecture. So we learned many points from you. Main thing is following the protocol. I think if we check the machine anesthesia workstation properly, whether oxygen availability and all, I think we can avoid most of the complications and the stress related to it. And definitely once the complications start, we lose our temper, start yelling at others, then our juniors get upset. I think it is a vicious circle. So following the protocol, having good food, good sleep, so many things we learned. Thank you so much, ma'am. It's a wonderful lecture.
Thank you. Thank you all.
So now we'll move to the next topic by Dr. Nilesh. So there's been what we are seeing is there is rising trend in medical negligence cases registered in the court these days. So the apprehension among the anesthesiologists regarding the legal issues is also raising. So the next lecture is by Dr. Nilesh. What can land anesthesiologists in the courtroom? So Dr. Nilesh is a consultant radiologist as well as anesthesiologist. He is the founder and the current president ISA Konkan and current president IMA Ratnagiri. He is a GC member of Maharashtra ISA, secretary AMC Ratnagiri, trustee in Federation of AMC of India. He actively practices both specialties, radiology as well as anesthesia. He was the training faculty for CPCR workshops under the name of Ayushdan at Sion Hospital for Maharashtra Police between 1999 and 2001. So instrumental in formation of the first association of radiologists in Ratnagiri. And he is IMA National President Awardee for Best Effective Creative Designs on Digital Art. So over to you, Dr. Nilesh. Got to listen to you.
Is my screen shared? Am I audible? Can I speak?
Yes, sir. Yes, sir. You are audible and your screen is also visible.
Okay, so I'll start with a Sanskrit couplet for all of us, amongst us who can understand. The couplet is Ashvam naiva gajam naiva vyaghram naiva chanaiva cha ajaputram balim dadyat devo durbala ghataka. I will explain the meaning for everybody. Ashvam naiva gajam naiva, a horse. Now what this couplet is about is sacrifice. Sacrifice of an animal to please the deity. So Ashvam Naiva, a horse is never sacrificed or is never the preferential sacrificial animal, and so is not an elephant. Ashvam Naiva, Gajam Naiva, Vyaghram Naiva cha Naiva cha, and a tiger is never a sacrificial animal, but Ajaputram means the young one of a sheep or a goat. Ajaputram balim dadyat. It is always the young one of a goat, which is the preferred sacrificial animal. Devo durbala ghatakaha. Even gods favor sacrificing the weak. So this picture, which I am showing now on the screen, before you make up your mind about what this picture is, I will tell you what this picture is. This picture is of a scene of a modern day sacrificial altar or a sacrificial scene. And what is missing in this is the sacrificial animal. And here comes the sacrificial animal, that is none other than you yourself. So, why is it so? Why is it so? Because out of a surgeon and an anesthesiologist, it will be the out of a patient and a doctor, the doctor will be weak. In a hospital, a corporate hospital and an individual doctor, the individual doctor will be weak. And between a surgeon and an anesthesiologist, you will always find that we are the goats or the young ones of a goat. So my topic is anesthesiologist. Do you know what can land you in a courtroom? I'm not going to go blah, blah, blah about negligence, commission, omission. Most of us have already heard a lot about this. And I will like to throw light on some other aspects of litigations against us or against anesthesiologists besides negligence. Of course, negligence forms a major component, but I am not here to tell you how you should not be negligent. I am here to tell you to imagine other areas which can bring in litigation in your day-to-day practice. In the course of narrating those causes of litigations or those reasons which can land you in a courtroom, I will like to explain and try to explain to you newer and varied terms like medical incompetence, medical misconduct, active negligence, gross negligence, medical misdemeanor, fiduciary relationships. What are fiduciary relationships? Vicarious responsibilities, tortuous liabilities, so on and so forth. What is a doctor-patient relationship? Doctors and patients share a legal fiduciary relationship which is contractual in nature. I will explain. I'm sure in this whole sentence, the only word probably which requires explanation is fiduciary. We all know what is a contractual relationship. I will like to explain what is fiduciary. So a fiduciary relationship has some certain essential components. One party in a fiduciary relationship is dominant and the other is subordinate. Am I well audible to everybody?
Yes, you are very
perfect.
Perfect.
So fine, thank you. So in a fiduciary relationship, one party is dominant and the other is subordinate, essentially. Second, powerful party is subject to higher standards of performance than usual relations. Third essential prerequisite is the powerful party takes upon itself the well-being and safety of the weaker party. The weaker party reposes its faith and trust on the stronger party by default. So it means that the weaker party, the moment the weaker party enters this relationship, which is called a fiduciary relationship, that weaker party reposes its faith and trust on the stronger party by default. The last and the fifth essential component of a fiduciary relationship is in cases of dispute, the powerful party is presumed to be at fault. Now, what is this presumed to be at fault? The burden of proving innocence is on this party, the powerful party. Am I clear with the 5 components of a fiduciary relationship? I'll give a couple of examples. Of course, a doctor-patient relationship is a fiduciary relationship, and a guru-chela or a guru-shagird or a religious guru and a disciple is a fiduciary relationship, because all disciples enter into this relationship with complete faith on the guru. Whenever a breach of a fiduciary relationship or a doctor-patient relationship is alleged, there are certain liabilities which arise, and all those responsibilities are breached in this kind of a complaint or alleged breach. First, there is a contractual burden, that is, the powerful party has breached the contract. There is a tortuous liability. What is a tortuous liability? Do you understand the meaning of the word tortuous? No, the tort is the first chapter which is taught in legal curriculum. Doctors are expected to be straight. Doctors are expected to be straightforward. So anything that is not straight, or that is teda meda, or that is curvy or tortuous is a tortuous liability. So your behavior, if you have engaged in a tortuous behavior, you have the liability of facing a tort case. A tort is a case where somebody alleges abnormal and twisted behavior from the vicarious responsibility. What is a vicarious responsibility? Where a doctor is responsible for the acts of his subordinates. We all know what is a vicarious responsibility. Moral commitment and ethical binding. Moral commitment, all of us know that there is a moral commitment on doctors to conduct and discharge all their duties as expected, and there is an ethical binding. What happens if each liability is breached? When a contractual burden is breached, law of contracts are invoked, tortuous liability, law of torts, vicarious responsibility, Consumer Protection Act. Moral commitment is not honored. What happens is there is a lowering of esteem And if ethical binding is not honored, there is a peer group embarrassment. In your association, in your doctor's fraternity, everybody will start talking about you and will cause an embarrassment to you for having breached your ethical commitments. What is professional incompetence? Now here I would like to draw attention to everybody's attention to a fact that negligence is a ghisa pita concept, and everybody knows that whenever you get a notice, the 90% of the times it is because of negligence. There is something called as professional incompetence, which we all need to get sensitized to in the current times. What is professional incompetence? MCI defines it as a failure to exercise due care and diligence in professional responsibilities due to two reasons: lack of knowledge and lack of skill. So, when you can't, failure to exercise due care and diligence is negligence. We all know that. No diligence is diligence, and negligence are antonyms. So we all know that failure to exercise diligence and care is negligence. But when this negligence is attributed to lack of knowledge or lack of skill, it metamorphoses into a new liability or a new entity called professional incompetence. The Medical Council of India has a code of medical ethics. I am sorry for using references from Medical Council of India, because though the National Medical Commission has already been formed, these nitty-gritties are not yet clear and not available in public domain yet, like they were in the case of Medical Council of India. So I'm still using the references of Medical Council of India because there is not going to be a landmark change in these thumb rules. So the Code of Medical Ethics of Medical Council of India read: professional incompetence should be adjudged by somebody in the Medical Council. So who judges professional incompetence? It will be judged by a peer group committee which will follow MCI guidelines. What is a peer group committee? For those amongst us who may not understand or may not have understood, peer group means a group, doctors, people from our own community. Peer group committee. A committee of doctors will follow MCI guidelines and judge whether the person alleged to be incompetent is indeed incompetent or not. Now, this kind of peer group committee is formed at the level of the clinical establishment. Now, because you are all from Navi Mumbai, I will take an example of, say, Apollo Hospital or say, MGM Hospital. So, a committee can be formed at the level of MGM Hospital. Whenever a patient writes a complaint to the dean that Dr. Nilesh has breached the contract of medical treatment and he has not behaved as in tandem with expectations, and I allege him to be incompetent or negligent or whatever, then the MGM hospital can constitute a committee at their level. That is called the level of clinical establishment. The complainant goes to the local civil surgeon or medical officer of the municipal corporation or the dean of a medical college in that region or the civil surgeon of a district. In that case, at the level of that institution, a committee can be formed. So in my case, in Ratnagiri, it is the civil surgeon. In Thane, it can be the dean of Rajiv Gandhi Medical College. In Vashi, it can be the collector, or it can be the medical officer, or it can also be the civil surgeon if there is a civil hospital in covering the whole of Navi Mumbai. Then if a complainant goes to a state medical council, that peer group committee can be formed by a state medical council. And at the top of the pyramid is Medical Council of India, which can also form an committee of experts to investigate into the charge of incompetence. The committee invariably consists of a chairperson, an IMA nominee, and another doctor who is a specialty expert. This is the minimum constitution. There can be more doctors and more members in the committee, which is the peer group committee. And the peer group committee has a burden of conducting their business in the following format. They have to conduct a time-bound inquiry. They have to follow principles of natural justice. For those amongst us who don't know what are the principles of natural justice, if whoever is alleging that the doctor has failed in discharging his duties, both the sides should get adequate, optimum, and repeated opportunities to put forth their points and defenses. If this is followed, then it is said that this investigation has followed principles of natural justice. You apply Bolithos Test. How many of us know what is a Bolithos Test? Can you please answer? Does anybody know? I will tell you what is a Bolam's test. And also the committee has to forward a reasoned out speaking order. What does a reasoned out speaking order mean? That a committee is not expected to give a 2-line order, he is negligent or he is not negligent, he is clean. Such 1 and 2-liners are not allowed. You have to elaborate as to what was the investigation, what were the findings of the investigation, and why does the committee feel that Dr. X is or is not culpable or has not been negligent or has not been incompetent. So it has to be descriptively reasoned out. It cannot just be a gospel statement. He's not. ऐसा नहीं हो सकता है. This is what a reasoned out speaking order means. Bolam's test. For those amongst us, have you heard Bolam's test? Heard about it? Okay.
No,
Can I request?
we don't know. We don't know who's Bolam's. Please tell us.
Yes. Bolam's test has been named so after a patient named John Hector Bolam. He was admitted in a hospital called Friends Hospital. He was a psychiatric patient. He was supposed to be given electroconvulsive therapy. This is a very old case. And when in those days ECT was given, each time it was not essential that ECT would be given with general anesthesia or muscle relaxation like we have been giving in our times. That time there were ECTs given with muscle relaxation and without muscle relaxation also. When John Hector Bolam was given an ECT, there were 4 or 5 sisters or nurses standing by the side of the patient and he was given an ECT. He was not restrained physically. The ECT was administered. His body threw a wild convulsion, a wild movement, and his hip joints, his shoulder joints, all sustained fractures. His acetabuli were fractured bilaterally, and he had a major hip joint crush injury kind of fracture. John Hector Bolam went to the courts and said that my ECT was not given in tandem with the current practices or with the proper medical expected behavior. I was given an ECT without muscle relaxants, because of which my body behaved abnormally under the ECT and I sustained fractures which were avoidable. On this claim of John Hector Bolam, the courts ordered, now the judges were not aware of what he was saying and what were the actual medical practices. So they referred this matter to a committee. Now the committee of doctors went into the details, and what happened was that the committee was divided vertically into 50-50. Half the people said that muscle relaxant should have been given, and half of them said that ECT is indeed given without muscle relaxation. So nothing is wrong, or there is nothing wrong if muscle relaxants were not used. The court said that if half the doctors believe that muscle relaxation need not have been given for the ECT, then the current practices indeed allow ECT to be given without muscle relaxants as well. So if these particular doctors have discharged their duties in tandem with the current practices, even if 50% of the people follow those practices, they have done their job reasonably well. This is the Bolam's test. So if a doctor in sane mind applies the practices which are currently in vogue or implemented in the society at that time, and if a doctor of his qualification normally will adopt X, Y, Z protocols, then if the doctor in question has followed X, Y, Z protocols, he is not negligent. This is the Bolam's test. So the Bolam's test means that you ask these questions. Number 1, is this doctor qualified? Yes. Is this doctor in sane mind? Yes. Has this doctor done everything that any reasonable doctor of his qualification in current times would do? Answer is yes. So the Bolam's test is positive. All the answers are yes. The doctor is not negligent. This Bolam's test was used from 1959 or 57 till now. Recently, the civic society and the consumer activists, they were very unhappy about this Bolam's test, because they used to say that who is the expert committee? Doctors. And you want the doctors to say something grossly against another doctor who is being alleged to be negligent. So this Bolam's test will never be adverse to the doctors. Then came the Bolithos test, and all the consumer activists are against Bolam's test being applied, and they believe that Bolithos test is the right test to be applied. What is Bolithos test? I will be a little fast in my narration of Bolithos Test because I feel I have dwelled a little bit too long on this. Patrick Bolithos was a small child who was suffering from CRAW, a respiratory disorder. He was admitted in a medical facility, and a doctor and a sister were appointed to look after the child. The parents were wealthy enough, and they had hired special nurses to take care of Patrick. The doctor who was caring for Patrick would instruct the sister to give certain treatment and would go out to the other hospitals on rounds and visits. What happened was, in the absence of the doctor, on one occasion, Patrick went into an apneic spell and he became cyanotic. The sister immediately called up the doctor and informed the doctor that Patrick is not breathing. But before their conversation could end, Patrick quickly came out of his apneic spell, started breathing, and his cyanosis was clear. He became pink again, he became conscious and was playful. The sister informed this to the doctor. This sequence of events happened thrice. All the 3 times before the doctor could come to the hospital, Patrick came out of the apneic spell, was cleared of cyanosis, and became pink and playful thrice. The 4th time this happened, and before the sister could tell the doctor and the doctor could come on the hospital premises, Patrick's apneic spell prolonged longer than expected, and he arrested. This time, he did not return and come out of apnea. He arrested and succumbed to that episode. In this case, again, the parents of Patrick dragged the hospital to the courts, and the doctor and sister were blamed for negligence. Courts again constituted a committee. Here again, the committee was vertically divided. Half the committee said that Patrick should have been intubated. The doctor should have visited the site, observed Patrick, evaluated Patrick, and should have passed an endotracheal tube. 50% of the doctors said for a small child like Patrick, intubation is also too invasive. And as it is like before, even if the doctor would have visited Patrick and been standing next to Patrick, probably he may not have intubated Patrick, given the risks involved with invasion, with the endotracheal intubation and the invasion associated with it. On this, the court said, now here, let me draw an analogy. Bolithos Test also, doctors were half divided. Bolithos Test also, doctors were vertically divided. But the court made another and a different observation. The court said that even if the doctors say that Patrick would not have been intubated, despite the doctor being close to Patrick, in this case, the circumstances are unique in the fact that the doctor was informed that Patrick is going into apneic spells and becoming cyanotic. The doctor failed to be by the side of Patrick on 4 occasions, of which the 4th was fatal. So, what the doctor would have done if had he been close to Patrick is a different issue or a different question altogether. That the doctor did not come to the side of Patrick the 4th time is negligence. And at the end, the court observed, the judges said that hence any expert committee opinion has to stand the critical analysis of the judiciary. So just because the doctors are saying that he would not have been intubated, or he should have been intubated, or should not have been intubated, why was the doctor not close to Patrick? Hence, though the opinion of the expert committee could have saved the doctors in Patrick's case, the court said that the opinion of the expert committee does not stand the critical analysis of the judiciary. Bolithos Test adds that expert opinion is not the final judgment. This is why the civil society believes that Bolithos Test is better than the Golem test. So now, whenever these Bolithos or Golem test is applied and we arrive at the negligence or incompetence of a doctor, here I would like to tell you there is a pyramid of competence. It's called the Competence Pyramid. And all of us listening to this talk are on some or the other sector of this pyramid. The bottom sector is called unconscious incompetence. Unconscious incompetence, the words itself mean that you don't know that you don't know. The doctor who is unconsciously incompetent believes in his competence, which means he is incompetent, but he believes he's competent. So he is unconscious of his incompetence. This is the most dangerous sector of the competence pyramid. The second sector is conscious incompetence. You know that you don't know X and Y portions of your specialty. I am an anesthesiologist. but I know that I am not good at cervical epidurals. I am an anesthesiologist, but I know that I am not good at ultrasound of the chest for finding out why the SpO2 is not rising. So I am sure about what I am not competent of. This is a better sector than the lower one, conscious incompetence. Then comes conscious competence. You know of your competence and you are confident of it. That is conscious competence, a higher category, and it is a good sector of doctors who are conscious about their competence. And the best sector is the top of the pyramid, unconscious incompetence. Competence has become a way of life. You are so sure of your competence that you don't need to consciously dissect and evaluate each time and find out, I am going to do this. Am I really competent to do this? You are unconscious because you are so competent that despite being unconscious, you are going to accomplish the task which you are taking at hand. This is the competence pyramid. All of us need to understand where on this pyramid we lie for each aspect of our professional practice. I'll give you some examples. Ayurvedic postgraduates in anesthesia are professionally incompetent to administer modern Western anesthesia. Secondly, a qualified anesthesiologist assisting a surgeon in a surgical procedure after administering anesthesia, he is incompetent for assisting a surgeon and is also negligent as an anesthesiologist. So he's an incompetent doctor as a surgeon and he's a negligent doctor as an anesthesiologist. And I'll give you a gray area of competence. An anesthesiologist doing an ultrasound to diagnose a pleural or pericardial effusion is one thing. He might be competent to do that. But then he goes ahead and taps it for diagnostic or therapeutic purpose. Here is a gray area. He is likely to be called incompetent for tapping it because he should have called a physician or a surgeon for the job. Doing an ultrasound to identify the cause of low SpO2 or low saturations is good, but to tap it may or may not be the anesthesiologist area as per the court's evaluation. Medical misconduct. I have finished talking about medical incompetence. I'll now come to medical misconduct. There are two components of medical misconduct: breach of confidentiality and breach of privilege. What is breach of confidentiality? Patients come to us with trust, belief, faith, transparency, and 100% reliance on us the moment they come to us and tell us everything about their health. We are expected to collect their data and lock it into our knowledge, not let it out to anybody for any reason whatsoever. I will give you a small example. I will request our esteemed members who are listening to this lecture to switch on their microphones, because I am going to narrate a story and ask a question. You are called at Dr. Karkhani's hospital. I am addressing this to all the anesthesiologists who are listening. You are called at Dr. Karkhani's hospital by this lady doctor who is named Dr. Karkhani's for an MTP on Mrs. Rao. Mrs. Rao happens to be the wife of your friend Vivek Rao, who stays and works abroad. The MTP goes well, you ascertain the well-being of Mrs. Rao after the MTP and you depart from the hospital, you leave the place. A month later, you meet Vivek Rao at a Rotary Club dinner, and after exchanging pleasantries, you ask him, how is your wife doing, Vivek? So he says, why, what's wrong with my wife? And as an anesthesiologist, you say, why? I was there a couple of months back. I was involved. I was there for the anesthesia of an MTP on Mrs. Rao. Now, you saying this to Vivek has caused a problem. The pregnancy of Mrs. Rao was a pregnancy out of wedlock. Mrs. Rao had faltered in a weak moment of loneliness. Vivek didn't know about it. Mrs. Rao loves her husband Vivek, wants to save her marriage, but your disclosure has brought a storm in the Rao household. Now, my question to all of you is, do you feel this is professional misconduct on your part? Can people answer please?
Yes.
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 Wonderful. So everybody here, everybody on board believes that this is misconduct?
Yes.
Yes. Yes.
Yes. Yes.
Yes, definitely it's
Good,
a
good.
misconduct.
Good. Thank you. Wonderful. Wonderful. So I am talking to a woke crowd. So privilege can, so in fact, I am telling you this here. I would like to very, very clearly say, I don't need to tell you this. I need to tell this to a crowd which is divided in opinion. When people say that, no, after all, you are telling this to the husband of the patient. So he ought to know, or that you believing that he knows about it is very natural. But the fact remains that you are not supposed to divulge anything to any other relative, even from the close family of the patient, unless it is expressly consented, unless it is explicitly allowed. So you have no reason to talk about it to Vivek Rao, even if you have been involved with the MTP of Mrs. Rao. So privilege, because this is a privileged information that you have got, and you are not supposed to divulge it to anybody. So privileged communication can be disclosed only in 5 specific circumstances. Besides these 5, if you are divulging the same information anywhere else, you are indulging in a professional misconduct. Which are those 5 peculiar circumstances? 1, when a patient has consented that you can tell about my illness to X, Y, Z, or anybody you desire. When the patient poses a danger to the self or to others because of the patient's medical condition. When a patient discloses an intent to commit a crime. If the patient, in the course of narrating his problems and talking to you, expresses an intent to commit a crime, you can certainly go to the law enforcing agencies and notify them about the medical condition of the patient, even if it is a privileged information. This is the 3rd. 4th is when you suspect abuse or neglect of a child or a vulnerable adult. In the story of the patient, in the history of the patient, if you suspect a peripheral or a transient mention of an adult or a child being abused, that is a cause for being disclosing privileged information. Or when a court orders for records, irrespective of how much ever personal and private the data is, you will have to put forth the data. This is another case I will like to bring forth before you. It involves an anesthesiologist, a bird of our feather. In Dular Singh Daulat Singh Zarade, who was a petitioner. This is a case, Dular Singh Daulat Singh Zarade versus State of Maharashtra, 2012, Aurangabad bench, case heard by Mr. Joshi and Nirgude. Facts of the case are, the petitioner was a prisoner in Aurangabad Central Prison. He applied for parole from jail on the grounds of his wife Sangeeta being unwell and that she required special attention. Petitioners relied upon a medical certificate. By petitioners, we mean the person, Mr. Zarade, and his lawyers. The petitioners relied upon a medical certificate dated 10th of April 2012, issued by Dr. Devayani Deshpande, who was an anesthesiologist from Aurangabad. The certificate of Dr. Deshpande read, this is to certify that Srimati Sangeeta, wife of Dular Singh Zarade, is suffering from severe icterus and anemia. Her husband should be with his wife for her care for at least 1 month, starting today. This is what the anesthesiologist had written. The court said, the decision of the court was the parole demand was rejected on multiple counts, which were mostly technical, related to the eligibility of that person for parole. But at the end of the decision, the judges mentioned that the medical certificate relied upon by the petitioner does not inspire confidence. The sickness or ailment described is vague. Gentlemen, the words I am using here, I have directly picked up from the judgment of that case. The certificate is issued by an anesthesiologist who does not practice as a consultant in general medicine. The practitioner's intent in issuing such a certificate appears to be malified, and she should desist from issuing such certificates. This is what the court said. Now here, since the matter was trivial, the order was made, in this order, the judges made a simple note of the malified intent, because parole was as it is rejected or denied. But they have passed scathing remarks about the doctor's intent in issuing such a certificate. This qualifies for medical incompetence or medical misconduct, issuing these kind of certificates. Medical misdemeanor. You are called for the MTP of an unmarried, purportedly or allegedly 19-year-old primi gravida. You believe the hospital records related to the patient information, particularly the patient age. She is medically fit. You administer the appropriate anesthesia and exit from the scene. Patient's relatives later on file a rape case against the man who was responsible for this unmarried primi's pregnancy. Police storm into the scene or into the hospital, impounds all the records, and makes the hospital and you, the anesthesiologist, party to the crime on various grounds. Not informing, what are the grounds? Not informing the police station about the victim being a minor. Recording false details on the medical records to assist the culprit in avoiding serious provisions of law under POCSO. For those amongst us who don't know the full form of POCSO, it is protection of children from sexual offenses. So they have come to a conclusion, the cops have come to a conclusion that she's not 19-year-old, the girl is minor, and you have recorded false details because you, along with the hospital, have recorded her age as 90, when actually she is less than 18, probably 17. She is not a major. And in order to prevent this case from going into the purview of POCSO, you have hobnobbed with the hospital, and in connivance with the hospital and the patients, you have written a wrong age. This is what has happened in my own town of Ratnagiri. So this is not an imaginary case. This kind of allegations are slapped by the cops on all of us. Despite being anesthesiologists, under the pretext of being in a hurry to go to the next hospital, you cannot afford to not pay due attention to the patient's demographic details and other social information related to the patient. Simple wrongdoing. Photography or videography of patients without consent is a simple wrongdoing. I will quickly run through medical negligence. Definition is failure to exercise reasonable care in one's actions, resulting in injury or damage to another person or property is called negligence. It is caused because of two acts of omission, acts of commission. But what is important more than this definition of negligence are the components of medical negligence. What are they? Innumerable components. Criminal negligence, collateral negligence, comparative negligence, concurrent, continued, contributory, active, passive, ordinary negligence, gross negligence, sole negligence, and willful negligence. There is a definition of each component of these negligences. And you, depending on what your alleged negligence is categorized as, will determine whether you are eligible for an indemnity insurance or whether you can be indemnified for this negligence or not. I will explain only a couple of them. Active negligence. Negligence due to the participation in some affirmative actions resulting in harm and or failure to perform a precise duty agreed to be performed. You are accompanying a patient in an ambulance from one hospital to another. You have agreed to perform the duty of transferring the patient, but before you reach the other hospital, you talk to the doctor on phone and you tell him that I saw a patient RI and I have told you everything about the medical condition. I'll just get down at the prior junction and I have an urgent other call to attend, so I will leave. This is failure to perform a precise duty agreed to be performed. This is active negligence. You have actively seen to it that you are negligent in this particular responsibility. Gross negligence, something which goes beyond a mere matter of compensation between subjects and involves a show of such blatant disregard to the safety and life of others that it amounts to a crime deserving punishment. I will like to read the salient words within this. Please remember, it goes, the key words are something which goes beyond a matter of mere compensation, something which shows blatant disregard to the safety and life of the patient, and something which amounts to a crime deserving punishment. Try to understand, it does not deserve only a monetary compensation. Isko itna paisa do, compensation is done, so the wrongdoing is nullified. This is basic. But here, it is not just monetary compensation. You have done such blatant acts that it amounts to crime which deserves not compensation, punishment. That is gross negligence. Do you know this? That if the word gross negligence is used against a doctor, his indemnity policy becomes null and void. The indemnifying insurance company will say that if a gross negligence is claimed and later on proved, we will not indemnify you against the outcome or the fallout. So try to understand that why you need to know the components of negligence. At gross negligence, Even if you have a 5 crore rupees indemnity policy, gross negligence, if claimed and alleged and proven, your indemnity policy is of zero value. So if you believe that you have an indemnity insurance and you do anything, or you have done something which is being alleged by the patient, and if you are wrongly confident that my indemnity policy will take care of me, believe me, the umbrella of indemnity insurance will disappear just by the usage of the word gross negligence. Then you will keep explaining to the insurance company, Aisa nahi hai, I have done this, I have done that, but nothing will be heard. And then you will be like this ICU patient where only he feels that he is covered. And like you feel from your indemnity, you feel you are covered by your indemnity when actually you are not. So coming to the next portion of this presentation, I would like to give you the platforms on which the patient can seek reliefs from against your misdeeds. There are 9 platforms. One is a civic health authority, like I told, local doctor in charge of that region, civil surgeon, dean of medical college or whatever. District collector, aggrieved patient can go to the state medical council of India, consumer court, civil courts, criminal courts, National Human Rights Commission, and Competition Commission. One more thing, if your acts or rash behavior or negligent behavior or incompetent conduct is strongly believed by the patient and his lawyers, and if it qualifies, then the patient can approach all 9 at the same time. If you are under the impression that wo pehla district collector ke paas ja sakta hai, then he can go to the state medical council. Then if he is not happy, he will go to the medical council. He will go to the civil court, or then he will not go to the criminal court. Aisa kuch nahi hai. He can go to all these 9 places on day 1 whenever he desires to. This is the most dreadful component of patients' civic rights, which we all need to be aware of. So, wow, I'm sure you must have all thought, Competition Commission, what does it have to do with my practice? Friends, how can a doctor land in a court because of a Competition Commission issue? Is that there are 2 components, restrictive trade practices and unfair trade practices. Now, Dr. Jessie Venel has a hospital, and I approach her for anesthesia engagements in her hospital, and she says, sorry, I will go the other way. There is a patient admitted with Dr. Jessie. The patient tells Dr. Jessie that I want Dr. Nilesh Nafde to be my anesthesiologist. And Dr. Jessie says, no, sorry, I cannot call Dr. Nilesh Nafde because we don't believe in calling Dr. Nilesh Nafde. We will only call Dr. Reenal or Dr. Alvina or Dr. Manisha Ghosh. This is a restrictive trade practice. If a patient says, I want Dr. Nilesh Nafde, and you really don't want to call Dr. Nilesh Nafde, the only option can be the hospital should say that, look, we are more comfortable working with Dr. Nilesh Nafde. Is it okay if we call him, or are you sure you want to call Dr. Manisha Ghosh only? And if the patient says, no, I want to call Dr. Manisha Ghosh only, then number 1, either you call Dr. Manisha Ghosh to satisfy the requirements of the patient, or you ask the patient to go to another hospital where Dr. Manisha Ghosh can be made available. Unfair trade practices. I go to Dr. Jessie and tell her I want to be an anesthesiologist in your hospital. She says, wonderful, you're most welcome. Please deposit 25 lakhs with my hospital, because all the anesthesiologists whom I call have already pledged some funds as an earnest money in my hospital. This is an unfair trade practice. You are expecting quid pro quo in exchange for professional work. Have I exceeded my time? Is it time up? Should I conclude?
You continue. How much more? Because
okay, I will rush through.
Yeah.
Okay. I've understood from what you told me. I will just rush through.
No, Thane people are ready with their webinar, so they would also want to hear.
Okay. So I'll go through this. I'll not go through this. I'll go ahead. So what are the do's and don'ts? Practice
Nilesh,
extreme diligence.
Nilesh, 1 minute. Jessie, our webinar is not today, huh? It's tomorrow.
It's tomorrow. Okay, again and again I continue.
Yeah.
Nilesh, please continue.
Sorry to disturb. It's tomorrow.
Yeah, no problem. Nilesh, please continue.
Yeah. So do's and don'ts. Do's are practice extreme diligence, study your indemnity insurance policy, even the fine print, and be well studied about what your indemnity offers and what it doesn't. Don't visit hospitals where besides you, there are anesthesiologists of Indian medicine. That is, there are Ayurvedic anesthesiologists. Don't visit those hospitals. So first find out who are your fellow anesthesiologists, if there are any others, because one patient can be attended by you and the Ayurvedic anesthesiologist. and you as a team can be booked for certain acts of negligence. Don't visit hospitals who don't show you or don't have an institutional indemnity insurance policy. The hospital has to have an indemnity insurance policy besides your professional indemnity insurance, because the hospitals often tell doctors, "Aap apna indemnity insurance nikalo." So that is fine. But even the hospital has to have its own institutional indemnity. If they don't have it, you are running a risk of not being compensated for negligences which are categorized as hospital responsibilities, not doctors' individual responsibility. Perform professional acts only for which you are professionally qualified, skilled, and competent. Obtain certifications of your professional upgradations and secure related documents. You feel that you are competent for this part of anesthesia is not enough. You should have some sort of upgradation certifications which reinforce your claim of being competent. Don't transfer a critical patient unaccompanied. Don't build psychological barriers. This is most important. Don't build psychological barriers in yourself about stigmas associated with notices, inquiries, litigations, and suits. Open up with your friends, co-professionals, co-anesthesiologists. Bluntly tell them that I have received a notice. Patient has claimed so and so. I feel I might have committed an error. This is likely to have happened. Or I feel that I am not at fault, but still I have received a notice. Be very blunt and talk to people. Don't live in castles with barriers around you and stop talking to people about your own litigations. Act in tandem with everything mentioned in the consent you have obtained in letter and spirit. And don't click photos or videos of the anesthetized patient and store, share, or propagate them without consent. It is blatant professional misconduct. I'll just rush through this. Now, whenever somebody wants to book a liability against you, they want to decide your culpability or frame charges against a doctor, there are certain prevalent theories which are used to book the liability, decide culpability, and frame charges. What are those theories? I will tell you in short a couple of theories. In this picture, the pedestrian is being banged by a four-wheeler, who, even if the pedestrian is wrongly crossing the road or crossing the road at the wrong time, the sympathies of the onlookers are going to be with whom? With the pedestrian or with the four-wheeler? The answer is with the pedestrian, not with the four-wheeler driver. Now, between a four-wheeler and a two-wheeler, if this accident occurs, onlookers will be sympathetic towards whom? Two-wheeler or four-wheeler? I am presuming your answer. Yes, yes, Jesse? Two-wheeler. So the sympathies will always be with the two-wheeler. So what is active here is called the deep pocket theory. The deep pocket theory believes the person who has a deeper pocket is likely to be more culpable. जो बेचारा गरीब है, वो बेचारा भी है, वो गरीब है, इसके लिए वो बेचारा है, और वो बेचारा है तो वो निर्दोष ही है. So this is how it thinks. This is called deep pocket theory. So person with a deeper pocket is always culpable. In this picture, please switch on and tell me, somebody tell me, in this picture, sympathies of the onlookers are with whom? With the sumo wrestler or with the weaker person, right? Between husband and wife, invariably the husband is the powerful component or partner, and hence most of the times what will be believed is that the strong and weak theory will go in favor of the lady. Here it will go in favor of the weaker person. So in a doctor and patient, you have to imagine who is strong and who is weak. Friends, this poster is of a movie called Thugs of Hindustan, which was actually created and a brainchild completely of Amir Khan, who was the Indian version of Johnny Depp. Now, this movie miserably failed. There was this glamour quotient of Katrina was there, the star of the millennium, Amitabh Bachchan was there, but this movie failed. And the onus of this failure was squarely put on the head of Amir Khan, right? Nobody said that Amitabh Bachchan was the cause of failure of Thugs of Hindustan or Katrina Kaif did not deliver. That is why Thugs of Hindustan failed. At the same time, out of these four people who run Kaun Banega Crorepati, Indrajit Chakrabarti, the person on your left, the second is Ashish Govardhan, who is content head of Sony Entertainment Television, Mr. NP Singh, who is the chief financial officer of SET. They are all responsible for the success of KBC. But we all know who is considered the person who is the cause of KBC being hit, Amitabh Bachchan. So this is called as the captain of the ship theory. It is the captain of the ship who is responsible for the victory or failure of the enterprise. Now, whenever a doctor is being adjudged by a court, always remember the deep pocket theory. Will it be in favor of patient or doctor? It will be in favor of patient. Powerful versus weak. Who is powerful, doctor or patient? The doctor is powerful. And the captain of the ship theory, who is the captain of the ship in a hospital, doctor or patient? Always the doctor. So believe me, all these three theories work against us. So whenever there is a litigation, the higher likelihood is that we will be at the receiving end. So you need to be aware of your limitations and your rights. You need to be informed about your policies and your protections. You need to be prepared whenever you handle a case. You need to be indemnified adequately, and you should know how far you are indemnified and be alert. That's all I want to say, and give you in the end one fact that the wheels of honesty, integrity, responsibility, morality, priority, and duty are all interconnected, and one wheel makes the other wheel turn. I feel I have finished my talk. Thank you. Thank you very much. I am open for any questions if anybody has.
Thank you, Dr. Nilesh. It was a very informative and excellent lecture. So, participants, if you have any questions, you can unmute and ask.
I'm grateful to Swati for her lecture. She taught about deep breathing. So when Nilesh was talking, most of the time I was practicing that. Deep breathing. Thank you, both of you. Excellent talk, Reena. Thank you.
Dr. Nilesh, I had one question. Like you said, if there is any other practicing anesthesia, like Ayurvedic doctor practicing anesthesia in some hospital, why we should not practice in the same hospital? Like if they are practicing independently, then what is the issue regarding that? Dr. Nilesh, you have to unmute. Dr. Nilesh, you are mute.
Okay. Can I be heard? Am I audible now?
Yes. Yeah.
See, I agree with your contention that if that anesthesiologist is independently practicing, what's the harm in you working at the same hospital? Can you always be sure that you are involved with the patient, and in the intra-op, post-op, or in the ICU or the recovery room, besides you, that particular anesthesiologist will not be involved with the care of the patient. If there is any doubt about this, if you are not sure of this, then you working in a hospital where the other Ayurvedic anesthesiologist is also there is a big risk, because I'll give you examples. Plastic surgeries or surgeries which go on for 48 and 72 hours. It is impractical. It is never possible that you are the sole anesthesiologist for all 72 hours. Somebody else will take over from you. Who will take over from that? Somebody else is not in your hands. Post-operatively, who looks after that patient in the ICU is not in your hands. The patient has been put out of, say, some drugs like some blood thinners and all. Who starts those blood thinners again is not in your control. Particularly, I'm talking about anesthesiologists. So decisions which are not in your control, if another person of your specialty can take those decisions, that person has to be equipotent like you in academic qualification. If that person is from an Indian medicine discipline, you are running and if there is a mishap in this particular case, the patient drags everybody to court. Let me tell you, the cops are not intelligent to understand the latest case in Thane, in a hospital where a mop or a surgical instrument was left behind. The anesthesiologist also has been involved with the case by the cops. Now, you feel the cops are intelligent enough to understand that ये anesthesia का काम नहीं है, इसमें सिर्फ surgeon को लेना चाहिए. They don't understand this. They take everybody inside. They mop up all the doctors whose names appear on the record and they book everybody. It was the sad responsibility of that anesthesiologist to acquire bail. For bail, they had to engage good lawyers, spend a lot of money. All these woes can come to your life just because you worked with somebody who was not appropriately qualified. Now, if you are working with anesthesiologists of the allopathic discipline and still this happens, you will still go through the same trouble, but at least you are sure that you can talk to those anesthesiologists being of your own fraternity and your own discipline. That is my contention, and hence you should, if you are sure, I will reframe your question. I will answer your question in another way. If you are sure that an Ayurvedic anesthesiologist and you will not cross paths ever in that hospital, you can work with that hospital, no issues.
Can I add to this? Like
Yeah.
the situations
Yeah,
you've been describing, Dr. Nilesh, there also could be a situation where there's a re-exploration or something on the patient and you're not available immediately for that. Post-cesarean, there's some bleed, post-hysterectomy, patient is sinking, needs to be taken up in emergency, you're not available and they call somebody else. Also, within 24 hours, if there is another, like burns patients, there are dressings to be done. And within 24 hours, if another procedure is being done on the patient, we cannot let go of our responsibility because the drugs that we give and our anesthesia responsibility carries on till that time. So be cautious always and try to avoid what Dr. Nilesh says is perfect. I just agree with him.
And you know, you have to make a fixed rule and thumb rule for your professional life and your professional career. आमतौर पे ऐसा होता नहीं है, लेकिन इस केस में ऐसा हो गया, उन्होंने उसको बुलाया. अरे, but you should have made a thumb rule that you don't want to work in a hospital where Ayurvedic anesthesiologists are working. If you would have done that, you would have saved yourself all this harassment of going to the cops, police stations, giving written explanations, appearing before the expert committee and all that. It's a harassment, believe me. It literally sends shivers down everybody's spine when they face this.
Also, I've always avoided giving anesthesia to Ayurvedic surgeons. I have got calls from hospitals where the Ayurvedic surgeons are doing some procedures, and I've always refused.
Yes, I agree.
I have one question. See, nowadays, now there are a group of surgeons who are working together. Now, one person starts the case, second one takes over, then the plastic surgeon comes, and then when I'm inducing or when I'm reversing, suppose there is nobody around, not one person is around. Who becomes liable in this kind of situation? The primary surgeon. Yeah.
See, anyway, if it is a surgical problem, the alleged complaint is related to a surgical problem, we are never going to be concerned with the claim of the patient, come what may. But as far as what you mentioned, if there are 3, 4 or different types of surgeons involved, and you want to know who out of them will be considered liable or culpable, I feel that that will have to be decided after a major brainstorming, litigation and case and all that. You have to be sure that your documents are safe, perfect, your medical records are up to date, and you can also, still I'll tell you, you said that there is no surgeon present at the time of reversal. Even if one surgeon is present and there is a complication, still you will have to go through the same drill. So the answer is that as long as you have to create records that anesthesia wise everything was perfect, you have discharged your duties 100%. So in such scenarios, see to it that your records, your notes, everything are perfect. That's all you can do.
Thank you.
Yeah, and one more thing, like multiple surgeons are involved. Same way, sometimes I've seen those who do cases one after other. Sometimes anesthetist hands over the case to the other anesthetist and he goes for some other case. Then something goes wrong, who is responsible?
Both the anesthesiologists. If you are sharing the revenue, you are sharing the case, you are sharing the happiness, you will share the sorrows.
Thank you, Dr. Nilesh. It was wonderful.
Unless you trust the other person, don't try to take over a case halfway through from somebody else.
Right.
You never know what has been given to the patient before you take over.
Right. Okay, I think it's going to be 8 o'clock. We'll wind up the session.
There is a question in chat box. One. If,
diploma in anesthesia can be an intensivist. The question is, diploma in anesthesia, can they manage ICU as an intensivist, right? Yeah.
Is that the question? Can a diploma in anesthesia manage a critical care unit? This is the question?
Yeah.
Certainly, if the DA candidate is able to document competence in the area of intensive care by his postgraduate education, by his post-diploma certifications, by his observers' posts or anything, if he's able to document that he's competent to be an intensive care, competent to deliver intensive care, even if he's a DA, it can be good enough. Absolutely no problems. But then it is the responsibility of that DA candidate to see to it that he has enough documents. If tomorrow the lawyer of the opposite party claims incompetence, you should be able to slap all those documents on the face of the claimant and say that I am qualified, I am experienced, I am certified, and hence I am competent.
Okay. Fine. Thank you, Dr. Nilesh. I think any more questions? Again, I thank our speakers, Dr. Reena, Dr. Swati, and Dr. Nilesh. It was wonderful. Learned a lot. I think it's a very vast chapter. We have to learn in detail to avoid all these complications. So anyway, I thank all the speakers and I thank Dr. Divekar ma'am, Dr. Manisha ma'am, and Dr. Archana for joining and encouraging us. I thank Dr. Jessie ma'am, our president, and thank all the ISA Navi Mumbai members, participants for joining and encouraging us. And I thank Dr. Varsha, our technical support. Okay, thank you. Thank you all again.
Goodbye.
Goodbye.
Thank you, everyone.
A gentle reminder, tomorrow at 5 o'clock, we have an online meet by Cover You Insurance Company, because it's on the same lines. They have tied up with ISA to guide us about professional indemnity. So everybody who's already having an indemnity or wants to change over or wants to start their own new one, please attend that. You will be you'll be guided on how to go about it. We will give you a reminder on the group also. Thank you, Alvina.
Thank you. Thanks all of you once again.
Good night. Good night, everybody.
Bye.
Thank
Good
you very
night.
much.
Good night. Good night, everyone.
Thank you very much.
Good night, Divekar ma'am.
Thank you, Reena.
Thank you, ma'am.